So still we are having in good morning only. Post tea, people will be awake. So we are in new session of new antibiotics. In fact, it's not a new antibiotic, very old antibiotics is like that old wine we are putting in new bottles because we now need those things. So the topic I have been allotted in next antibiotic is fosfomycin. Very quickly, in just 10 years, we have reached to the state of this statement by CDC that if we don't preserve our antibiotic, we don't use it properly, we are going to have a time where nothing will work. And very quickly we have reached to the stage now. In fact, I was happy Hemant was saying that carbapenem he doesn't use. In fact, almost last 1 year I have not written any meropenem or imipenem to any of my patients. Because either they come pan-drug resistant, either they come sensitive to other lower antibiotic, they don't need carbapenem. So that's what. So coming to the issue of fosfomycin, it's old. Rather, it was decommissioned antibiotic like colistin because it was initially thought to be toxic. Then gradually it came to be used as a oral medicine to treat uncomplicated UTI. But gradually people have started recognizing that it works well in MDR and XDR bugs. May not be working well in the sensitive bugs, but when there is MDR and XDR, because of its structure and it works well. Coming to this origin and formulation, we need to understand that intravenous formulation has got disodium content, very high content in sodium, and when we use fosfomycin, there is always a risk of causing hypernatremia, and if you infuse it very fast, it causes hypokalemia as well because of the rapid infusion. So this thing has to be taken care, and that's why we need to know the structure of this molecule. Oral formulation which we use is a 3 gram single sachet, while the injectable format, the calcium formulate is not used commonly, is although available, and the injectable formulate is 1 to 8 gram injection available in disodium content. Now, this aspect of the antibiotic use we need to understand for all antibiotics. This antibiotic has not so been used in animal because other antibiotics is being used for animal for their treatment or just to make them grow better, and then we get microdose of antibiotic, all of us who are non-veg, and then we get resistance because that's one of the mechanism which is being given for us. So we have to understand that this molecule is not being used for animal, very sporadically for some of the like broiler chickens and piglet, but there also it stays for 7 days in their body if one dose has been given. So relatively safe in that aspect. Mechanism of action, it works as it is a bactericidal antibiotic and it interferes with the bacterial cell wall synthesis. What we need to understand that it has got not one mechanism, it has 2 mechanisms. First thing, it works in initial step of cell wall synthesis. Along with that, it has got G6P pathway to enter in another way. Along with that, it reduces the adherence of bacteria to urinary epithelium. That's why it is being used for UTI, and it also reduces the receptor at respiratory epithelium. So Streptococcus pneumoniae or H. influenza for that is very effective because of the suppression of platelet activating factor. It has got immunomodulating property. For pro-inflammatory modulator, it decreases their production from their respective cell, or for anti-inflammatory mediator, it increases the production. Along with that, it enhances the neutrophil phagocytic activity. So if we look for the properties, it's very favorable for us to use that. It works in biofilm. Why we need to know about that? That we know that most of the resistance, particularly the bacteria which become resistant, they grow inside biofilm. And the concept of biofilm, breaking of biofilm is being used as a antibiotic lag time. That means there are few trials where they have first used fosfomycin followed by another antibiotic, where it breaks the biofilm and another antibiotic works over there. Not too many trials, but there are few small case report and studies, and where they have found favorable result in form of bactericidal activity or clearance of bacteria is concerned. Spectrum of activity, it has been claimed that it works. It is the claim which was made initially, but there are some changes after 2010 when we started studying in intravenous form that I will come to you. But it is claimed to work on gram-positive like Enterococcus, both the species, which is not correct. It works better in Enterococcus faecalis than Faecium. Doesn't work in all MRSA, but yes, it works, but it's not related, anything related to be vancomycin. MRS, it works in MRSA, but nothing related to vancomycin. It works in gram-negative, particularly in Klebsiella and E. coli. But we have to remember that initially it was claimed that it doesn't work, it doesn't at all work in Acinetobacter, it doesn't work in Pseudomonas. But there are some trial which has started coming now, which is showing that in MDR Pseudomonas with combination of colistin, it has good bactericidal activity and good clinical improvement rate. Apart from that, it doesn't work in all anaerobe and in Morganella it doesn't work. Intracellular bactericidal activity. This is something which we need when we are dealing with bug like Staphylococcus aureus or Listeria monocytis, where it works. It has got intracellular bactericidal activity and that's why it is useful. So particularly if you are using in like bone infection where there is osteomyelitis, where you need to use this drug and where you need to have a drug which works intracellularly, this drug is very useful. Looking for the culture sensitivity report, like colistin, if somebody reports to you that has got zone of inhibition, probably that report has not to be accepted. We need to have a clear-cut MIC of this drug, particularly for gram-negative, at least Enterobacteriaceae and where we are using. For E. coli, yes, you can use zone of inhibition, but preferably we should use MIC. So do not accept the report which comes like zone of inhibition. Always ask for the MIC of this drug if somebody sends you the report. The studies which has come after 2010, particularly in XDR or MDR bug, this is a lot of these are the not really RCT but observation and prospective or retrospective studies. And what they have said, what they have concluded that in gram-positive infection, only 33% of the MRSA strain were susceptible, not which was initially claimed like that. Apart from that, in Enterococcus faecalis has better sensitivity than Enterococcus faecium. In gram-negative bug, particularly ESBL, E. coli and Klebsiella pneumoniae, it has got better sensitivity. E. coli has better sensitivity than Klebsiella pneumoniae, but Proteus it was least susceptible. It was found to be active in 90 to 100% of MDR Enterobacteriaceae. But again, we have to remember that it doesn't work in Acinetobacter at all. But 80% of the carbapenem resistant Pseudomonas strain were reported to be susceptible. Although the drug itself is intrinsically, Pseudomonas itself is intrinsically resistant to fosfomycin. So this finding variation, why is working on MDR, I do not have answer, but these are the data which I got and just presenting in front of you. Could not get the explanation for that. It acquires resistance by the mutation in uptake system, changing enzyme activity. One very interesting mechanism of resistance is it has alternate pathway, soluble pathway to generate UDP enzyme and where it develops resistance. So it is not like resistant to development of resistance, it develops, but cross resistance report is less. Now coming to synergism and antagonism, that's what because fosfomycin so far is not being recommended to use as a standalone drug. Wherever we are using in combination with other drug, particularly to treat the MDR bug, particularly Klebsiella or other Enterobacteriaceae. Different combination has been tried, but if you start seeing the data in ESBL producing Klebsiella pneumoniae, it was around 43 to 78% of the carbapenem has sensitive synergistic action. Some has just reported only 7% colistin and etylimycin has synergistic action. While in carbapenem resistant Klebsiella pneumoniae, synergism was better. 70% of the carbapenem has synergy, while colistin has 36. So we start seeing the different observation study. Probably fosfomycin and carbapenem has got better synergistic action than fosfomycin and colistin according to this. In fact, if you have NDM bug, colistin it works, but if you use tetracycline, it doesn't work with that. And there is an antagonism if you have OXA48 producing Klebsiella pneumoniae. So it means not only we need to have this gram-negative this E. coli or Klebsiella, we need to know little bit detail about them when we are using in combination, because if you are using OXA48 bug with colistin, it can even antagonize it. Pharmacokinetics, we all are interested in knowing for each and every antibiotic. This drug so far has been used as a oral fosfomycin for UTI. It is a water soluble drug, doesn't bind to protein, and it achieves bladder concentration within 4 hours and stays for 24 hours. That's why one dose of the oral fosfomycin in single dose 3 gram has been recommended to treat uncomplicated UTI. But if you are dealing with complicated UTI, they recommend that 3 doses can be given after 48 hours, up to 3 doses can be given to treat complicated UTI. But what we are interested in knowing about the parenteral fosfomycin, how it works. It's a response is both time and dose dependent. That's really complicated, like colistin. It works on time as well as concentration dependent. So you need to achieve a concentration also, and you need to achieve a time also. 40%, its half-life is around 1.5 to 2 hours. It's not metabolized in liver. It is secreted by the glomerular filtration. You need to have a normal renal function to give full dose. If renal dysfunction is there, you need to reduce the dose. Very interesting feature about this fosfomycin is it reduces the nephrotoxicity and ototoxicity of aminoglycoside by reducing the uptake of this drug at renal level. It distributes predominantly in extracellular fluid. As I said, it works both by concentration and time. That means to get maximum bactericidal killing effect, you need to achieve 8 times of the minimum inhibitory concentration of 40 to 50% of the time. So the dose preferably has to be given in BD, but suppose you decide to give 16 milligram of the dose, that 16 gram of the dose, you give 8 gram BD dose. If you decide 12 gram, you can give TDS dose. But one has to remember that if you want to get, another important thing is that the drug has to be given, has to be diluted in 5% dextrose, not normal saline, not half normal saline, because of the high sodium content, and preferably has to be given over 2 to 3 hours. If you give it rapid, dangerous hypokalemia can develop, and that can create problem. If you want to give it for CNS purpose, the dose has to be double. For AKI and renal replacement therapy, if creatinine clearance is above 60, no need to reduce the dose, and if there is renal dysfunction, accordingly you prolong the time but keep the dose same. If you are using CRRT, you have to give 8 gram 12 hourly same dose. But if you are using for hemodialysis dose, you give according to creatinine clearance, but 1-2 gram dose after dialysis you need to give. Hypernatremia, hypokalemia is there something. Although this drug do not get metabolized in liver, but some of the case reports are there where raised SGPT was concerned to withdraw the drug in 2-3 cases. Now coming to the clinical use of fosfomycin, where do we all use? Treatment of uncomplicated lower UTI is well established for oral, I don't need to discuss too much. Use of parenteral fosfomycin in combination with synergistic antibiotic. So far, I did not see any data where they have used as a standalone drug to treat any MDR or XDR bug. Even it has been used initially for severe pneumonia, Staphylococcus enterococcus meningitis, it has been used. It has been used for MRSA where they were not responding to vancomycin or even daptomycin, where there has been used. But in a bug where patient is critically ill and where there is a pan drug resistant or extensive drug resistant carbapenem producing gram negative bacteria, there in those small trial, a small observation where bugs were predominantly Klebsiella pneumoniae or Pseudomonas aeruginosa. Here it came because here the bug was both Klebsiella as well as Pseudomonas, and what they found that fosfomycin could have a place in armamentarium against XDR or pan drug gram negative infection in critically ill patients, because eradication was observed almost in 56% and 28 days mortality was almost only 37%. So it could clearly. Same way, fosfomycin plus imipenem as a rescue therapy where daptomycin or vancomycin was not working to treat MRSA endocarditis. The drug has shown to give better result in comparison to the vancomycin. Efficacy against infection caused by MDR, again in this is this article what they have said that indication for efficacy of parenteral fosfomycin, especially against XDR and pan drug resistance, they found that provides a unique opportunity to describe the use of fosfomycin and assess its efficacy, especially in MDR bacterial infection, even in clinical situation. What I do, because this drug is not very old, we have started using in SARS since last almost 8 months or so. This drug I keep as a preserve where there is a confirmed report of pan drug or extensive drug resistant Klebsiella pneumoniae. So far we use this in combination of colistin, not alone, because initially when we are using Klebsiella pneumoniae and whatever drug, even carbapenem or colistin or whatever combination we are using, the success rate was not that good. But at least now we are able to manage the patient with combination of fosfomycin and colistin. As far as MRSA infection is concerned, what has been quoted in literature, or as far as Pseudomonas is concerned, we have better options so far. We have not reached to that stage. We do not deal day to day in ICU for that kind of bug where we have to deal. But this drug gives another option. But suppose you are having MRSA where it's not responding to your daptomycin or vancomycin, combination of this can be tried. So what I will think that for Klebsiella pneumoniae, we should keep this drug as a reserve drug. If somebody wants to use for pan drug resistant Pseudomonas, that can be another option in combination with colistin to use it. But be careful not to use this drug for Acinetobacter infection. You should not be assured like if you are giving fosfomycin and somebody is growing MRSA, it will take care. No, you have to combine some other drug to treat MRSA. Standalone, this drug will not work for MRSA infection. This is all I have to say. Thank you. I finished my time. Done? So, good afternoon, and very quickly to answer this question, antimicrobial therapy, monotherapy versus combination therapy, do we have answer? So, my answer is I don't know, because it's not me only, even Surviving Sepsis campaign, if you have read, they also don't know. The recommendation which they have, I'll just let you know what they recommend about and why they recommend about. But still we don't have a very hard-code randomized controlled trial which clearly says that monotherapy is superior to combination therapy or combination therapy is superior to monotherapy. Okay. So just a few terminology. What do you understand by empiric therapy? When we start antibiotics in a given situation where we don't know what we are treating and we probably want to cover every possible bug. So initial therapy they recommend should be broad enough to cover all suspected organisms. How we suspect organism? I will come to the criteria. That means your empiric therapy is going to be mono, combination, broad spectrum or multi-drug in nature. Where do you place? I will let you know. When we come to target or definitive therapy, here we know the organism and we start treatment. So when we know the organism is starting treatment, why do they need to recommend the targeted therapy may be mono or combination, but is not intended to be broad spectrum. Here again they have confused you. These are all definition I am taking from guideline. What is saying? What we understand by broad spectrum therapy, according to their definition, one or more antimicrobial agent with the specific intent of broadening the range of potential pathogen covered. Means, if I want to treat Pseudomonas, I want to give 2 or 3 drug to eradicate it fast. But it's not like that. You can have Pseudomonas, you can have a patient also fungal infection or MRSA also. So here they want to give piperacin tazobactam to cover Pseudomonas. they want to give vancomycin for MRSA and they want to give inhalable fungin for suspected fungal infection. This is broad spectrum therapy. The rationale behind this is they want to ensure that at least one antimicrobial should cover the probable bug, and then multi-drug therapy. Multi-drug therapy can be empiric, where we don't know, or it can be definitive, where we want to accelerate the clearance, like we combine piperacillin tazobactam with aminoglycoside. And then comes the combination therapy. What I mean, when anybody talk about combination therapy, what it means? If we go by this definition, piperacillin tazobactam, vancomycin and enrofungin do not fall in the combination of classical combination therapy as per this definition. It comes under the broad spectrum therapy, where we want to cover the probable bugs which we suspected. But when we say it's a combination therapy, it means we want to use multiple antibiotics, usually of different mechanistic classes, with the specific intent of covering the known or suspected pathogen with more than one antibiotics. The classical example, piperacillin tazobactam, aminoglycoside, piperacillin tazobactam, quinolones or azithromycin. Purpose is to accelerate the clearance, or you want to inhibit the bacterial toxin by adding clindamycin or azithromycin, or you want to potentially use as an immunomodulator, like nowadays we use azithro or clarithromycin. The term is not used to broaden the range of antimicrobial activity. So here you have to very clearly understand that when we say combination therapy, it means we are intending to kill one bug where we probably know or know with two or more drugs to accelerate the clearance, according to this understanding. Okay. What do I mean by combination therapy? When I combine two drugs, it can be synergistic. That means combining two antibiotics, the effect will be more than their individual effect. That means 1 plus 1 is 3 or 11, not 2. While we say additive, it means 1 plus 1 is 2. That means if you combine both the drug, the effect of individual will be equal to the combination. But if it is antagonistic, it means due to some reason, if you have combined two antibiotics, they can cut down each other effect and effect may be less than 2. This is also very much possible. We need to be very careful when select antibiotic that we are not using antagonistic. Plus, most commonly used antibiotic nowadays is when you are combining colistin with tetracycline to treat pneumonia, particularly hospital acquired Acinetobacter pneumonia. There it has been found to be antagonistic effect. Now, as per their recommendation, what new guideline recommend? We recommend empirical broad spectrum therapy with one or more antimicrobial for patient presenting with sepsis or septic shock to cover all likely pathogen. Okay, this is what they say. The intention is they want to cover all the probable bacterial or fungal or viral infection. And the rationale behind this is if you delay in starting appropriate antibiotic in time, each hour delay increases the chance of increase the mortality in the patient. This came from one of the very important study from Dr. Kumar. And another problem is that if you delay or in starting appropriate treatment, probability of progression from gram-negative bacteremia to sepsis or septic shock increases and mortality increases. So this is one of the biggest fear when we select antibiotic. We probably want, all of us want to save the patient, and intention behind that is with these studies that we want to cover all possible bugs, and that's why we combine antibiotic. How we select appropriate antibiotic? We go by the site, probably by antibiogram or pathogen we know resistance mechanism, the presence of immune defect, comorbidity, antibiotic exposure, all this, and based on this there is a scoring system where you define which class this patient falls in, and accordingly in sepsis or septic shock we select antibiotic for any given site or pathophysiology. Their suggestion was combination therapy not be routinely used. Again, they are confusing you more. It should not be routinely used for ongoing treatment, means if you have continued the treatment for most serious infections including bacteremia and sepsis without shock. So if your patient is not having septic shock as per new definition, if your patient is not in septic shock, you don't need to start combination therapy. But it doesn't mean you will not start broad spectrum therapy. You will, according to your scoring system, you try to predict the probable bug, start the broad spectrum therapy, but you will not start the combination therapy. That means no need to start in general piperacillin-tazobactam or amikacin. If you are starting piperacillin for gram negative or meropenem for gram negative, one should be enough. Or if you are suspecting like that. So in general, if a patient is not in shock, but if same patient is in shock, in general, everybody recommends for the combination therapy. That's one thing is very clear. When you are dealing with neutropenic patient, if your patient is neutropenic and patient is having only fever or bacteremia, not septic shock, again no need to combine the antibiotic. In general, in neutropenic patient, that's the only class of patient where combination of antibiotic has shown negative result. So there is a very, very strong recommendation that you don't need to combine. But again, this does not preclude us from multi-drug therapy to cover antimicrobial. So if you are not clear about what combination, what broad spectrum or multi-drug therapy is, you will always be confusing this term. If you have started combination therapy, once patient start improving, you need to bring down for monotherapy in targeted or empiric therapy. Targeted therapy, I am okay. But if I started somebody empirical treatment and I don't know what bug I am treating, after 3 or 5 days, how can I come down and which antibiotics I should start? I don't know the way. If my patient has started on suppose colistin or meropenem combination, which antibiotic I should stop after 3 days or after 72 hours? If I don't have culture report, I don't know the way. But that's what they recommend. But here I have a serious question about that. Why do we combine antibiotic? The basic reason is we want to start initial appropriate antibiotic to decrease mortality. Everything, whatever is the reason here, but basic intent is that. Indication, if you have polymicrobial infection like abdominal sepsis, infective endocarditis and meningitis, pneumonia, very, very strong recommendation. I did not to take because TB and HIV is not our subject primarily, but there we know the, and if there is a severe infection with septic shock and multi-drug resistant organism. But all these recommendation is based on just retrospective studies or personal case based experience. It's not a definite RCT based recommendation. Combination can prevent resistance. We know in tuberculosis and HIV, and we know the reduction of beta lactamase production reduced. But if it happened, probably beta lactamase has never have come. Probably it could not do for ICU patient. But this is the basis of doing that. Now coming to the why do we say that antibiotics should be combined? What is the data we have? Particularly in this paper, because this paper has made recommendation for a lot of studies and lot of guidelines where this paper is being quoted why we need to combine. Early combination of antibiotic therapy yields improved survival compared with monotherapy in septic shock. This was a big paper by Dr. Kumar where he have analyzed even hour by hour. Not only he analyzed the time, he analyzed the combination and how fast you give antibiotic. And there he have very clearly they have said in a subset of patients where your patient is having septic shock, combining 2 antibiotic of different mechanism helps in improving the outcome. Same thing, and this is how he has shown, but he has very clearly also said, if your patient is not having septic shock, our risk of dying due to sepsis is less than 15%, but if he comes in lower category, and in that case if you combine antibiotic, possibility of increased mortality is high. So one issue is very clear, if your patient is not having septic shock as per current definition, you don't need to combine antibiotic. If you get a patient of sepsis with septic shock, you combine. If it's not there, you don't combine. You wait till you get definite culture report to start appropriate antibiotic. So okay? Same thing, he again re-emphasized in this commentary that combination antimicrobial therapy where a given pathogen is covered by 2 and more antibiotic with different antimicrobial mechanism by use may be useful in a subset of clinically ill patients, particularly those with septic shock. Okay. Here, this was a very big commentary in our Indian Journal of Critical Care Medicine, where he tried to see the current concept in combination antibiotic therapy for critically ill patients. The first line was, although it's a widespread use of combination antibiotic, but we don't have a definite data to support that. But more than one antibiotic is commonly used to treat such infection. Scientific evidence are not in favor of that, particularly if those bugs are MDR and XDR. It was a very nice communication and review of what is done, whatever reason it has been given. But again, if your bug is MDR or XDR, if you are suspecting, then combination of antibiotics make a case for this class of patient. But particularly for community acquired pneumonia, lower respiratory tract, in a patient which comes in category of 3 and 4, patient who needs ICU care, patient who comes with pneumonia with septic shock who needs ventilator. This has been a very, very strong recommendation from all guidelines that you need to combine antibiotic till you get definite culture report, and this has been undisputed recommendation and followed by. So this is one place where you will combine antibiotic to cover all probable bugs, including atypical and probably toxin producing bugs. Sometimes even you need to combine for gram negative 2 bugs, for atypical bugs like azithromycin, or sometimes you need to give even if you are suspecting MRSA to cover MRSA also in this class of patient. So here there is a patient which makes where you have to think for all those categories, including combination and broad spectrum antibiotic. And very clearly it has been shown that combining antibiotic in community acquired pneumonia, particularly severe community acquired pneumonia, improves outcome. A fact about community acquired pneumonia that 10% of these patients may have bacteremia, and this is because of the pneumolysin and toxin produced by this pneumococcus, and adding macrolides here is an advantage. So this thing we need to remember. Combination therapy, if I start going by data, there are some where they have compared piperacin, tazobactam and amikacin with amikacin. Probably it was not a fair thing to do. There is a definite advantage of combination therapy. But again, beta-lactam monotherapy versus beta-lactam and aminoglycoside, there is no. So if you just compare beta-lactam and aminoglycoside with beta-lactam, there is no difference. But again, for pneumonia, as I said initially, there is a huge difference in outcome. In neutropenic patient, it's very, very clear that you don't need to all ideas say, all the guidelines clearly say that you don't need to combine antibiotic. You need to give broad spectrum antibiotic, but you don't need to combine antibiotic as long as this patient is not having septic shock or on ventilator therapy. For fever or bacteremia, you don't need to give combination therapy for neutropenic patient. Generally, the meta-analysis for all the trial which has been done for combining antibiotic favors combination therapy in gram-negative infection. But whatever small trials are there, they do not favor combination therapy. What are the adverse events associated with combination therapy? It can be nephrotoxicity, class superinfection, fungal overgrowth, and sometimes antagonism we need to worry about. Particularly antagonism, you have to worry about 3 cases. As immunocompromised, that's why we don't combine. And when you are dealing with severe infection like localized meningitis and endocarditis. If your combination of drug is not appropriate, there is a high chance the same drug may become antagonistic to each other. So you need to be very, very careful when you are selecting your antibiotic. For carbapenem resistant Enterobacteriaceae, we have talked in detail that we combine fosfomycin and colistin, and that's why all the review articles favorable. But nobody has a definite trial to say that. So, as far as salvage therapy of multi-drug resistant infection is concerned, there are very limited observational study, but everybody advocates consideration of combination of 2 antibiotics. Of late, there are few studies, particularly prospective studies, which has come where people have started combining single colistin versus colistin combination. And I will not be surprised that in coming time, if somebody start educating, they find heteroresistance is there, that the colistin alone and colistin plus carbapenem, colistin plus other combination, if it is sensitive, is equally effective. So there are data where high dose colistin is being compared with other and found to be. And then in fact there was a big discussion on CCP one time when we were talking about combination therapy, where Dr. Farhad has said that he only used colistin. That's why he was the only person who quoted that I use only colistin to treat the sensitive bug, no other drug I combine. But there are few data which has started coming. If I get enough, I will also get confident to use standalone colistin. So far I do not use it. Very few small case reported, which is very interesting when the fosfomycin was not there, where people have started combining 2 carbapenem as a synergistic effect, particularly for Klebsiella pneumoniae. The ertapenem, particularly it works on Klebsiella, but when it becomes resistant, to increase the efficacy and to get additive effect, meropenem, carbapenem has been combined to treat. I had also treated around 5% when fosfomycin, but definitely it has worked for resistant Klebsiella. So if you don't have option, sometime you can try this combination for resistant Klebsiella. So just to conclude my talk in 2 minutes, the clinical data supporting combination therapy are neither overwhelming nor definitive. Meta-analysis evaluating RCT demonstrate no difference in clinical output when the 2 treatment strategy for definite management of infection with gram-negative infection. Well documented increased toxicity with combination therapy, you need to be careful. Gram-negative bacteria are served best with monotherapy, and it's always appropriate if you know the bug and if patient do not fall in the category of shock or immunocompromised or severe immunocompromised category, you may go with the single bug. Initiating broad spectrum empirical antibiotic therapy at the first suspicion of infection in critically ill patient is important, but you need to come down. When you suspect multi-drug resistant infection, including patient with compromised immune system with various ICU admission, recipient of broad spectrum antibiotic, empirical antimicrobial treatment should include coverage of pathogen that may be resistant to previous administered antibiotic. This you need to always consider, because suppose somebody was in therapy, was on piperazine tazobactam, has come to you with sepsis. You will not only suspect that patient may be resistant to that bug, but may be having pan drug or extensive drug resistant, and when you will select the gram-negative antibiotic coverage, it must cover the extensive or pan drug resistant coverage. But to avoid the further emergence of resistance and adverse side effect, antimicrobial regimen should be narrowed down. So we all recommend that we need to combine when there is adverse or septic shock. If there is no septic shock, if patient do not fall in the category of XDR, MDR category, selection of any single drug, but when I say single drug, I am talking about gram-negative coverage. If you suspect somebody is having MRSA and gram-negative, that's not a combination therapy. So 2 messages I want to give. You need to be very, very clear what you are doing. Are you doing broad spectrum coverage or you are doing combination therapy? And when you are combining, you need to be very, very clear that your patient should be in shock, septic shock, or should be having immunocompromised status, are very high likely to die because of that. If it's not there, if you can wait for 48 hours till culture report come, single antimicrobial will be as good as combination. But all these are based on the personal experience of everybody else or small case reported. We do not have a very big RCT to compare one versus other. And that's the reason I don't know clear answer. But this is what I know about combination versus single. Thank you.